Hello, my name is Giovanna Middlebrook, and I will be presenting on the article titled Safety and Efficacy of High-Dose Unfractionated Heparin for Prevention of Venous Thromboembolism in Overweight and Obese Patients. The article was published in July of 2016 in the journal titled Pharmacotherapy. At this point, there are no separate guidelines for VTE prophylaxis in overweight and obese patients, although it may be possible that they're not receiving optimal prophylaxis, especially because obesity is an independent risk factor for VTE, and studies have found that the incidence of VTE increases by 2 to 3 times as BMI increases to 30 to 40 kilograms per meter squared or greater. The null hypothesis of the study is that there was no significant difference between the incidence of VTE in overweight and obese patients that receive a high dose of unfractionated heparin, in this case it was 7,500 units every 8 hours daily, versus those that receive the FDA-approved doses of 5,000 units every 8 hours daily. This is a single-center retrospective observational cohort study that was performed at Memorial Hermann Texas Medical Center. The protocol was approved by the hospital's Institutional Review Board with waiver of informed consent. The hospital had also performed a previous study titled High-Dose Subcutaneous Unfractionated Heparin for Prevention of Venous Thromboembolism in Overweight Neurocritical Care Patients. And this study took place in 2015 and showed that high-dose unfractionated heparin was not associated with an increased risk of bleeding, nor did it decrease the incidence of VTE in the overweight patients. For the study that I will be discussing, the primary objective was the incidence of a confirmed VTE, and the secondary objective was the incidence of major and minor bleeding. The inclusion criteria for the study were adult patients, so they had to be 18 years or older. They had to be admitted to the hospital between January 1st, 2013 to August 31st, 2014, which is when the study took place. They had to weigh over 100 kilograms on admission and received either the 5,000 units every 8 hours or the 7,500 units every 8 hours for the prevention of VTE. The patients who were admitted with a VTE, those who had anticoagulation required or had a history of or were diagnosed with AFib during their hospitalization were excluded, as well as patients that had a stay of less than 48 hours or received enoxaparin for VTE prophylaxis at any point during their stay. Patients were categorized into BMI groups according to the 2013 ACC/AHA guidelines, and those that fell into the overweight category, the obese class 1, 2, or 3 were studied. Providers could choose prophylactic doses based on the individual and clinical judgment, and the patients were followed from hospital admission to discharge or death. The sample size was estimated based on the previous study that I talked about at their institution, and 1,788 patients were needed to statistically meet significance. This is with an estimated effect size of 9.3 in the high dose group and 5.7% in the low dose group. And this was assuming a power of 80% with an alpha of 0.05. However, only 1,335 patients were actually studied, and they used descriptive statistics to describe the population of these patients and the rates of their complications. The chi-square test was used for categorical variables, and the student t-test was used to compare the continuous variables. There was a multivariable logistic regression model that was used to identify risk factors for VTE, and a t-tail test of statistical significance was set at a p-value of less than 0.05. The tests used by the authors were appropriate and matched the type of data. Results showed that there was no significant difference in the incidence of VTE between the high dose and low dose group. This was with a p-value of 0.14. The multiple logistic regression analysis showed that only the high dose was associated with the incidence of bleeding. This was with an odds ratio of 3.4 and a 95% confidence interval of 1.58 to 7.42, with a p-value of less than 0.01. I think that this is an important study because it demonstrates that high-dose unfractionated heparin may not be a benefit to overweight and obese patients, and that they are actually adequately protected from VTEs with the regular dose of 5,000 units every 8 hours, especially if they're getting put at a higher risk of bleeding. However, I also think that a multi-center prospective study with a greater sample size is needed to confirm the complications of the high-dose heparin, and that it would also be useful to study other anticoagulant drugs in the overweight and obese population. This concludes the end of my presentation. Thank you so much for listening.